Today we're discussing acute coronary syndromes. These include unstable angina, NSTEMI, and STEMI. In unstable angina, the angina chest pain changes character, changes severity or duration. There could be EKG changes, but there's no troponin elevation. In NSTEMI, in addition to the features of unstable angina, there's troponin elevation and a new wall motion abnormality. In STEMI, the characteristic ST changes, that is, ST elevations, are noted. Heart attack is the leading killer, and in this presentation today, we're trying to crack the killer's code. Myocardial infarction is death of the heart muscle necrosis from stoppage of blood flow to a portion of the heart. In order to pinpoint the culprit, much research happened. In the early 70s, the cause was unknown. Subsequently, the etiology of the heart attack was ascertained. The lipid theory of cholesterol formation and deposition in the heart goes as far back as 1900s. The original scientists fed rabbits animal protein and cholesterol to ascertain the lipid hypothesis, proving that lipids got deposited in the arteries, causing the atherosclerotic plaque. Why a plaque gives a heart attack was unclear. This was clarified by the brave work done by Dewood et al. In the 80s, where they did angiograms on patients having heart attacks and showed that those who had angiograms done within the first few hours of the MI had a thrombus 87% of the time, proving that thrombus caused the heart attack and was not the result of a heart attack. This was because of plaque rupture, and the final clue as to why the plaque ruptures came from autopsy studies where they found lipid-rich plaque and thin wall endothelium leading to exposure of the lipids and thrombus formation. This idea of thrombus causing the heart attack led to design of large clinical trials called the ACS trials. In these trials, thousands of patients were enrolled with a simple approach, and the signal was separated from the noise by using a large number of patients. ACS 1 involved use of beta blockers. In ACS 2, they used aspirin and streptokinase. It was a 2x2 factorial design. ACS 2 showed that use of aspirin reduced the chance of the primary endpoint or death by 23%. Use of aspirin and lytics decreased the primary endpoint by 42%. Therefore, it became apparent that time is of the essence. Early administration of lytics had far better outcomes than delayed administration. Time to lytic administration ideally should be 30 minutes or less. Subsequently, people started having issues with lytics such as bleeding, including intracranial bleeding. This led to a new idea of developing emergency catheterization angioplasty, and the comparison was done in PAMI trial where they compared lytics versus balloon angioplasty and stent. At the 2-year follow-up mark, those patients who underwent primary angioplasty had a 27.2% primary endpoint requiring repeat intervention, whereas the patients that had lytics administered required repeated intervention 46.5% of the time. Therefore, there was an early mortality benefit and a late benefit from getting angioplasty. Primary angioplasty became standard of care. Going back to unstable angina versus NSTEMI and STEMI, focusing on unstable angina, there are multiple mechanisms of unstable angina, including plaque rupture, plaque vasospasm, plaque hemorrhage, and increased demand, and all of these need to be addressed. Selective patients can be taken to the cath lab. The intermediate NSTEMI patients are also cath selectively. Those who are in cardiogenic shock, congestive heart failure, exhibiting ventricular tachycardia or ventricular fibrillation are taken to the cath lab early, whereas the other ones are taken later for a late invasive strategy. Thank you for listening.